Today we had some chapters to go over on biofilm and calculus and extrinsic stain removal and fluoride. We had things to catch up for. I can take myself out of here. But that all is pretty self-explanatory in Wilkins for you. So what I'd like to do is mix things up a little bit and go over hard tissue charting, because you have an assignment coming up, which is due, I believe, next Monday. Your article critique is due, which we're going to discuss. Your philosophy of practice is due, and we're going to discuss that. And your hard tissue charting homework is due. So, and that's due to your clinical instructor. So what we're going to do with the hard tissue charting assignment is review it now. I'm going to have a short PowerPoint on it, and that is something else that's due next week. Now, this should only take you about a half an hour to do. Hopefully it's not hard. Those of you that don't have any dental experience, it will be more difficult, but there is a really good Procter & Gamble CE that I put into Canvas. That's not a CE anymore, but it has all of these charting symbols. What some students will do is they'll Google, they'll find other avenues to try and help. But what we have to do is be able to have a universal language, not only to talk about what where we're talking about and what we're talking about, but the exact place and that type of thing. So somebody says, isn't that due on the 9th? I don't know. I think I'm supposed to assign it. I don't know. I've got piles and piles of paper, so I don't know where my pile is for this particular assignment. So we're going to go over it now, because this is when we've got the time to be able to. So you're going to have a hard tissue assignment. This is going to be an individual assignment, but we're going to grade it, quote unquote, grade it as a group. So when you split up into your group with your with your different pods and instructors, we will go over this. So this is just something that you might be seeing. And will you be able to decipher what this particular hard tissue charting is all about? And that's what we need to know. Are you going to be able to decipher what this is meaning? There are more than one ways to chart things. Dentrix, which is the computer software, dental software that we have, charts things in a certain way. EagleSoft, there are a lot of other softwares out there, SoftDent, those type of things might have slightly different symbols. The American Dental Association has come up with universal symbols. Some offices will use their own color schemes. But the important thing is are they alike enough that you're going to be able to tell what is what from one chart to another? So just looking at this, what do you think is going on here? Number 2. What do you think is number 2, just by looking at the restoration or what's drawn in there?
It's an amalgam filling.
Is that the filling?
What are the surfaces?
MOD.
This would be an MOD. What's going on with number 3?
Is it
Furcation?
Lubrication.
Exactly, a furcation. And this particular one would be gingival recession as well. This is one reason why in the old days I loved these kind of charts, because you would be able to actually chart what you saw and how you saw it. Because if there was gingival recession, let's say up to here, and the crown margin was here, then you would know this would be root surface that's been exposed. So this would be a furcation. What do you think number 4?
Crown.
Crown.
Porcelain fused to metal crown. What does an S stand for?
Sealant.
Sealants.
Sealants, exactly, and so on. Now, this is one way to chart an implant. The tooth was extracted, there's an implant. This is a distal. All right, anything typically in red needs to be done. Anything typically in blue has been done or is existing. And some offices will also have green that is denoting what they have done. So for a new patient, you oftentimes are the first person to see that new patient, and you might be in charge of charting existing restorations, as you will be for your patients that are coming through the clinic. So again, this is just something that you might be needing to take a look at. Jonathan said this PowerPoint is in module 11, but we're going to go through it now. What kind of stuff do you need? Well, you need safety glasses, and by golly, they're here. You just couldn't have picked them up yet. Air water syringe, which we are really not allowed to use because it produces aerosol. A good mirror. This is one of those dual instruments. You've got a probe on one end and a number 23 Explorer on the other end, and then cotton forceps or pickups, whatever you want to call them. So let's take a look at hard tissue charting. You need to know the classifications of carious lesions. Caries is a process from the time it starts, demineralization starts, to the point where there's frank decay. And there's classifications, just like there are with everything else. Furcation, class 1, 2, 3, or 4. Furcations, okay? You're going to have the same thing with carious lesions. And these are things you need to know. You need to know them not only for clinic, you need to know them for your board exams, and you need to know them in private practice. These are GV Black classifications. Class 1 is an occlusal caries, or a buccal and lingual, or a buccal or lingual pit. Class 2 is posterior interproximal. Class 3 is an anterior interproximal. Class 4, anterior interproximal, including the incisal corner. Class 5 is at the gingival margin of the facial or lingual or buccal. And then a class 6 is a cusp tip. So these are caries classifications. What a lot of students will do is actually have a picture of these in their dental help book, their dental clinic book, so that they can refer to it while they are doing hard tissue charting. Class 1, 2, 3, 4, 5, and 6. Then you've got your different types of restorations that you need to know about. There are things called preventive restorations, and those are really things that were done prior to sealants. I have preventive restorations. They didn't have sealants when I was a child, so they just did slight fissurotomies and put in a very shallow amalgam. I still have some of them. The teeth I have not broken, but there's amalgam, the silver filling restorations, composites, gold foil, inlays, onlays, veneers, crowns, temporary provisional restorations or temporary restorations. So we're going to go over all of this because we've got about half the class that does not have any dental experience. So preventive restorations are things that are done to prevent tooth decay. So there's no decay there yet. We want to prevent it. It's primary prevention. And that's what preventive sealants are all about. And there's also preventive resin restorations, which is with a glass ionomer. It's a different type of filling material, but this is what a sealant looks like. It goes into the pits and fissures. Now, this is a good example. This one doesn't have one. But what teeth are these? Is this here? Are these top or bottom teeth?
Bottom.
Bottom. Is this a first molar or a second molar?
Second.
Second.
Okay, and then this is the first because this is that distal cusp. Very good. So amalgam restorations are the old-fashioned silver filling restorations or fillings. Okay, we call them fillings because you're filling a hole. Okay, we also call them restorations because we're trying to restore the tooth back to its original function, form and function. So depending on your office, it's either a filling or a restoration. With the composites, we're calling them more restorations. Silver fillings have been around forever. And you can see that there is a fracture in the silver filling here. An MO. This is a DO with a buckle. Another DO. Can't really tell that much unless you know what you're looking for with the composite restorations, but if you look real closely, you'll be able to see the margin of the restoration. You can see slight discoloration here. There is something right here. This looks like an MOD here. So this is where your explorer really comes in handy because the composites feel just a little different than the enamel portion of the tooth. A lot of patients have the amalgams removed by now and have gone to composites. I was working with a composite dentist in the mid-90s a cosmetic dentist in the mid-90s who was priding himself on ripping out all of these nasty amalgams and putting in better composites. Well, the American Dental Association came out with a white paper saying that that is not best practice. If there's nothing wrong with it, don't worry about it. But as a patient, what would you prefer? Something that would look like this or something that would look like this as a final result? So when you get into dental materials, you're going to be discussing the different pros and cons of each certain type of restoration. There is still a use for amalgams, even though a lot of dentists aren't doing them anymore. But there are cases where it is beneficial for the patient. Now, gold foil is a type of restoration that we only see in dental schools now because it is so time intensive and technique intensive that patients can't afford it. But there's this tiny little gold foil piece, and you can see that these are the snake eyes, that mandibular first premolar. This is where you'll see the gold foils. And look at this. This is a class 5 gold foil. Gold is a wonderful material. It is caries resistant. There's not a lot of breakdown around it, but this would take hours to do. So offices aren't doing them anymore. Dental schools, the only time I've seen this is when I was a dental assistant in dental assisting school, and I had to go to Walter Reed to assist some of the military dentists who were learning how to do this. Has anybody seen gold foils in private practice?
No.
This is something that you'll see coming through clinic occasionally because the patients that we have as routine patients that come year after year after year love being patients in dental school environments because they're not only getting the best care, supervised care, but they're getting state-of-the-art care. So the only time I see gold foils now, and I ask the patient, where did you get these done? And it's going to be at some dental school, probably 40 years ago. They last a lifetime. Onlay versus inlay. An inlay is something that is withheld within the tooth, and onlay is something that takes a cusp tip, takes over a cusp tip. So this is an inlay here, porcelain inlay. It's an MOD restoration, but it's a lab fabricated restoration versus this is a porcelain onlay. Because this is the cusp tip. Inlay versus onlay. Again, inlay versus onlay. Did the lab fabricate it? Is it within the tooth or is it replacing the cusp of a tooth? This we would call a 3/4 crown because there's very little tooth left. You wouldn't see this anymore. They just go ahead and put a crown over that tooth. But you can see where you have to be very specific. An MOL. Mesial occlusal lingual porcelain onlay on tooth number 14. An MOD porcelain inlay on tooth number 13. Or actually, it's the other side of the mouth, but you have veneers, and veneers are like false fingernails, as I tell patients. What they do is they take just about 1 millimeter of the enamel off. They shave the facial and the incisal portion of the tooth. They take impressions, and then an enamel veneer or porcelain veneer is placed and bonded to that tooth surface. Now, there are things called lumineers and lots of different types of procedures out now where they don't even have to remove any of the tooth surface. But a veneer is a wonderful cosmetic restoration for closing up gaps between teeth that can't otherwise be closed. If this tooth was decayed here, but not all the way through and still sound enough, putting a veneer here with part of a restoration could save that tooth from becoming a full-fledged crown. You see a lot of the movie stars having veneers with those chiclet white teeth.
ما گفتم با او آدم میل مشتاقن آدم یا زنگ بزن پاتون با من شده. ایمان زنگ زده بود میگم کارا ما میگن ما تو تیر خانه.
Okay, somebody's got their microphone on.
یا ایمیل کنی. دمی دکونم ایمیل شون چی.
Who's got their microphones on? Okay, this is a crown. A crown we call a cap. Patients call it a cap or a crown. Okay, they're not talking to me. Okay, so look at this. The whole tooth is moved down. 1 millimeter is taken off of each surface. This is a porcelain fused to metal crown because this is the metal, and it fits over the entire tooth. When you see crowns like this, you can see the metal on the occlusal surface. These are usually done for patients who brux or grind, because if this was all porcelain, that porcelain could fracture, even though they were wearing a night guard. Temporary or provisional restorations. They can be made out of acrylic. They can be temp bond. They can be a number of different things. Zinc phosphate. So if you end up with something like that and you see it in your chair, you're not going to be scaling the mesial of that tooth, because you don't want to rip out that temporary restoration. Temporary crowns, usually cemented with temporary cement. They come out fairly easily. Endodontic treatment, root canal therapy, it's called. RCT, root canal therapy. That is where the actual pulp of the tooth is removed and the canals are filled with other material. The tooth is sealed, and then you have a permanent restoration placed over it. This is one reason why it's so important to have good radiographs. Look at the dilaceration and how these roots bend. The dentist needs to know that going in, whether they're doing a root canal or whether they're doing an extraction. Then you've got prosthodontic restorations, things that replace things that are missing. You can have fixed or removable. Fixed partial dentures, okay, which is a fixed bridge. A removable partial denture, something that the patient can pop out. Removable complete denture. And then there's implant supported prosthetic restorations. And you're going to be seeing all of these with your patients in the clinic. So a fixed partial denture, you have crowns that are fused to pontics, and the pontic is that false tooth. So they're missing the tooth here. So this is a crown, and then you've got your false tooth, a crown, and they're all fused together. So this is a natural tooth, this is a natural tooth, and this is a natural tooth. This is the pontic. So what the patient has to do is be taught how to clean, because they can't push the dental floss up like they normally would. So the dental floss has to go through threaders here, and then they'll take the floss and floss this side of the tooth. They'll take the floss and go over this side, and then the floss this side. Then they have to take the threader and place the threader here to floss in between.
Misty, I have a question for the pontic. Does the tooth just like float there, or is it like anything going inside the gum?
No, this is all fused together. So it's just floating.
Okay.
Just floating like this here. So this would be a tooth. This would be a tooth, and this is your floating tooth here.
Got it. Thank you.
Okay, so it's all fused together. So we would call this, when we're charting, we'd call this a 1, 2, 3, 4 unit fixed bridge. And then you'd chart it as 4 units. Like that, somehow. A Maryland bridge used to be very popular, and then it's not, and now it is again. So what a Maryland bridge is a very conservative bridge, and guess where it was designed? At the University of Maryland, duh, right? But you can see that they have these little wings here, and these wings are like little flaps, so that on the lingual of the tooth beside it, you have these flaps that are bonded to the tooth. So the only thing that's really removed is the lingual surface of the teeth where those wings have to go. So it's a very conservative, fixed bridge. The problem is it can't withstand a lot of pressure and tugging and force and torque force and that type of thing. So it tends to want to pop out. The only other solution that we had years ago where there was a missing tooth is to destroy the enamel on this tooth and then the tooth in front and the tooth in back to make a 3-unit bridge. So if this was a virgin tooth and this was a virgin tooth, you are literally taking a lot of the enamel off. Perfectly good teeth. So doing something like a Meulen bridge was the only option there. Now what would we recommend for a replacement of that tooth?
Implant.
Implants, exactly. You'd put in a root form here, screw type root form. And then there would be the prosthetic on top of that, and we could replace one tooth. It's about the same cost as doing one of these to replace the one tooth. Removable partial dentures, metal, all acrylic. You're going to see all sorts of different kinds. You want to have them taken out at the beginning of the appointment, and you want to do a thorough oral cancer exam. You want to clean these in the ultrasonic cleaner. You do have one skill evaluation that you have to do before you graduate on care of prosthesis. And it's an easy one. We'll walk you through that one, but it just takes you through where everything is and how it's done. But you want to educate the patient on proper fit and how to take care of them. Removable complete dentures. You have a chapter on the edentulous patient, so we're not going to harp on this. But if your patient has something removable, you want them to remove it when they're in the chair. Now, if you're taking radiographs and you need, let's say, a periapical because they've got this natural tooth here, you would have them keep their maxillary denture in to have them bite down on something. Occasionally, I've taken pans where the dentist has wanted me to keep the dentures in. So the dentist will guide you. If not, you'd have them take it out. Then you've got implant supported prosthetic restorations. The teeth are lost for whatever reason. After 4 to 6 months or longer, the bone, once it matures again, has a root form that is literally drilled in very methodically and slowly. So this is the root form. The bone integrates around it. It's called osteointegration. And then it's uncovered, impressions are taken, and then an implant can actually be placed on here. This is what you see from some of the original implants. You can see the threads. This is a failing implant. It's not pretty. Is it worth redoing? If it's not mobile, the dentist will oftentimes say, keep it until it becomes mobile. Hopefully their lip covers up that. So take a look at the implant here. How do I know that that's an implant? Do I know that that's an implant?
Gingival margin discoloration.
Exactly, Jonathan. You can see right here the translucency of the gingiva. Maybe it's a porcelain fused to metal crown. Who knows? But that's where your radiographs come in. And then this is a composite restoration here. You can see that the margin is not great because they're trying to close up a space. So your eyes are going to be zeroing in on these very minute details of your patient. Right now, they might not because you don't know about them. You've never seen them before. But as we go along and point these things out to you, you'll be able to see them for yourself. So this is an implant supported full denture. Sometimes these will be buttons that the patient can pop on and off themselves. Sometimes they are not. And the patient will come in here every 3 months, and you've got to figure out how to clean it because it's very time consuming to remove it. And sometimes they're made to where you don't know who was designing it, but you can't get anything in there. Can you imagine if the patient couldn't remove this, how are they going to clean underneath here? You will find some impossible situations that the patient is forced to deal with. So for your hard tissue charting, you're also looking at parafunctional habits. Parafunctional habits, what is the patient doing that's beyond what the teeth are normally or the mouth is normally supposed to be doing? Bruxism, that's clenching or grinding. Tongue thrusting. Every time the patient swallows, the tongue is going towards the front teeth and pushing on the front teeth. Mouth breathing, thumb sucking, or any other habitual habit used of the mouth unrelated to eating, drinking, or speaking. So that can be nail biting. Chewing on toothpicks, chewing on pencils. There's something called Meulen Classification. I am not going to get into this with you, but they have, even with parafunctional habits, they have scales for everything. There's a Bruch scale for bruxism activities. We don't get into that unless you are a TMJ practice. You might need to learn that scale, but basically that is, if they're a grinder, they're a grinder. There's a bite scale for biting activities. Are you chewing gum all the time? Are you chewing your nails? What are you doing? And then there's a soft scale for soft tissue activities, tongue, lips, those type of things, tongue thrusting. So they've got scales for everything. Do you need to know this? Heavens no. Attrition, tooth to tooth, wearing away, tooth to tooth. You're going to ask the patient if they grind. I don't think so, they say. Do you see those teeth just fitting like a puzzle? This is more of a severe case, but sometimes you'll see it subtle. And this is where you can see just little wear facets. And you'll see wear facets here. You can see the chipping. So when you have the patient do their excursive movements, so you ask them to bring their lower jaw forward so their front teeth are biting edge to edge, you're going to be able to see them fitting like this, or side to side for that canine protective occlusion, canine to canine cusp tip. The only thing that should be touching when you're a canine cusp to canine cusp, top to bottom, are the two canine cusps. And that's what you're checking. So when you're bringing the patient to an anterior bite and you're showing them, well, you might not be grinding now, but at some point you did, because this is the motion that your jaw was doing. And it's amazing to see the unnatural bite that people get into. Now, if you're a grinder and you're a night grinder, you're not grinding all night long. You're going through episodes of grinding. So it's a very sporadic thing. Do you remember what classification this is?
Classics.
Class 6, exactly. And this is not a normal place for caries because it's smooth surface. And there's no pit, there's no fissure, it's just wearing away. But if you wear the class 6 cusp tips away enough, you can see the dentin is exposed, and sometimes that gets soft. And then it needs to be restored. When I had one employer that loved keeping me waiting half hour, 40 minutes, whatever, I had nothing to do. So what I do is I just fill those suckers up with some sort of a glass ionomer. And yeah, they'd be worn down the next time, but it gave me something to do and it filled the holes. It worked. So this patient is a long-standing Bruxer. Parafunctional habit, attrition. Abfraction. This is attrition here. Look how flat these teeth are. They don't have any occlusal anatomy on them anymore. Abfraction. Every time the patient bites, there's this microscopic flexing that's done at the end of the CEJ for where the enamel is and the root surface begins, and you've got these wedge-shaped holes, so to speak. Goes through it, and you can see that this is the dentin, and then you can see the nerve canal here. Surprisingly, oftentimes these patients are not sensitive. Erosion is from a chemical eroding, sucking on lemons, sucking on something. GERD, if they have gastric reflux disease, they could be burping up gastric juices when they sleep and they're not aware that they have erosion. Bulimia. Commercials are talking a lot about acid erosion on teeth because we, as a population, are drinking all sorts of drinks that have an acidic pH to them. I am hooked on Crystal Light lemonade. It's sugar-free. It should be good for me. I'm not putting sugar in my mouth, but the pH of that is so low, I might as well be drinking a sugared Coke. So, erosion. You want to take a look to see where it is, the extent of it. Ask the patient about dietary habits. Open bite. This is a tongue thrust. You can see the tongue coming out here on this lower right. Open bite. And I can bet you when you're doing anterior, edge to edge, you're going to be able to see the mandibular teeth fitting right into this like a puzzle. A good time for patient education. Tooth decalcification. Is it decalcification? Is it hypocalcification? Hypocalcification is it was never formed. Decalcification is it was formed and then it's been leached out. Or is it fluorosis? You really don't know. So we're treating everything as if it is decalcification. White spot lesions, we're doing OHE and nutritional counseling on our patients. And cosmetically, we're seeing what we can do to help bring about those white spots and make them less obvious for the patient. Defective restorations, we're talking hard tissue charting. So you would chart the amalgam, would be an MO amalgam. It would actually be an MO L amalgam, all right, and then you would circle it in red. You would put in Dentrix that it had a defective margin, and it would put a red line around the blue amalgam. So red is usually indicating needs to be done. Blue is existing, and sometimes green is we did it here. Defective restoration. And this is just wrong on all accounts. Tooth staining, you have a whole chapter on that. What's the stain from? Is it from chlorhexidine? Is it from the bacteria in the mouth that is just creating the stain because it picks up stains from foods? Is it coffee, tea, smoking, iron? What color is it? What's the extent of it? What do you think the probable cause is of it? Chromogenic bacteria is just bacteria that some people have that like to pick up color. So this is extrinsic. This is stuff that you want to scale and polish off. Versus intrinsic, it's within the tooth. Nothing is going to get this off aside from dental procedure. This is classic tetracycline staining. You can see that it looks like a rainbow. We don't see too much of this anymore because about 40 years ago, somebody scratched their head and said, ooh, maybe it's the tetracycline that is creating this, and it is. So tetracyclines are avoided in pregnant women up through elementary school because we want to make sure that all the teeth, the permanent teeth, have completed calcification before that tetracycline is prescribed. So the top is intrinsic staining from tetracycline. This is one tooth that has intrinsic stain, intrinsic from within. Anybody want to venture what's going on there?
Is the tooth dead? Like the root of it?
Exactly. The tooth could be quote unquote dead. We don't know if the tooth has had a root canal. We don't know if the nerve naturally died from whatever or from trauma, whatever. So when a tooth is quote unquote dead, okay, it doesn't have any blood supply anymore going to the tooth. And there is a hemoglobin that's kind of leached out into the dentin of the tooth, and it creates that grayish black. This is more of a brown stain. But extrinsic bleaching trays usually aren't the best thing for this. They need to go in and do an internal bleaching. Now they've got a lot of whitening procedures out there now. Has anybody in their private practice experience had success with these type of whitening procedures? In my day, this patient, and I've had patients like this, would have had crowns placed on all of those perfectly fine teeth.
My mom had tetracycline graying of her teeth, and so she has veneers across all 6 of her anterior top teeth.
And do they look good on her?
They do, actually. They did a really good job.
Yay. And veneers, they even have to be careful with because some of the porcelain material is very translucent. So this grain, depending on what the patient exhibited with, the grain could show through. So they've got different materials and different bonding materials to customize for the particular patient. So luckily, we don't have to destroy perfectly good teeth anymore.
Miss D, just have a quick question on the intrinsic. So the chemical come from within the tooth. So if we do the bleaching on the first pictures, so the bleaching just cover on the surface of the tooth. So we still can see some color, some discolor.
It's been
Is that
very
correct?
ineffective. Whitening procedures have been very ineffective. What they've done also is they've given each tooth a root canal and gone in and bleached internally because it has to go from the inside of the tooth. Same way with
Right.
this tooth here. What they do is they open up the back of the tooth and then they bleach from the inside.
Oh, they bleach from the inside. Makes sense.
But again, that's a lot of drastic work for teeth like on the top that are perfectly healthy.
My dad had a root canal on one of his centrals. I can't remember which one. So his mouth kind of looks like the bottom picture. And he tried the internal bleaching, but it didn't really work.
It's too bad. And then you also, do we crown it? Do we not crown it? Is the tooth going to fracture? There's all sorts of controversies and philosophies going around. It's hard to know what the best treatment is for your patients and loved ones because there are so many philosophies. Now in oral anatomy, we're having a whole chapter on tooth anomalies, but you can see that there's these root surfaces can just be totally out of whack. This is what an enamel pearl looks like there. You can see how far down that probe goes, but the enamel pearl is a clump of enamel that is at the beginning of a furcation. There is no ligaments that are attached. So it's a furcation waiting to happen. What's this?
Is that a baby tooth?
No. If it's not, then what would it be?
Peg lateral?
It's a peg lateral. It's a lateral incisor. Remember those maxillary lateral incisors can be congenitally missing or peg-shaped. Those are the two most common anomalies for the maxillary permanent laterals. The bottom is, these are the Hutchinson's incisors or notched incisors and mulberry molars. This is trivia. Do you remember what that's associated with? It's associated with genital or with syphilis, congenital syphilis. When you have tooth fused to tooth on the root surface, we've had this in oral anatomy. Does concrescence sound familiar? Is that the only time this would happen? Generalized, yes, Alexis, it's the only time it would happen. Now you can see that all of these anterior teeth are affected. It's not just one tooth. Sometimes you'll have one tooth that is just really weird, you know, and that could be if it's one tooth or if it's a bilateral, it's usually something like a fever or something happened during gestation when the tooth was forming. But this is a generalized thing. So if you see somebody with one notched tooth, don't go, oh my God, they have, you know, congenital syphilis. Fusion versus gemination. Is it an extra tooth or is it the same amount of teeth with missing one root? So fusion, the teeth are just fused together. Gemination, you've got one root, but you've got two crowns. So that's where you have to be counting your teeth. canine to canine. So that's the first thing I do is I take a look at canine to canine, because more than once I've been messed up when I'm doing my perio charting or something where they've had an extra tooth or not enough teeth, and I'm one tooth off, and then you got to go figure out what you did wrong. Fusion, gemination.
So for fusion, do we count as one or
It's
just as two?
It's 2 teeth.
Okay.
It's the same number of teeth.
Same for gemination?
Gemination, you've got 1 tooth but 2 crowns, so this would be like an extra one.
Okay, so you counted like 2 still?
Well, no, it would still be 1 tooth, but you can see how it's kind of like this. Now, without a radiograph, we don't know if it's 1 tooth or two underneath there.
Okay.
Don't know which one it is. Dens and dente, tooth within a tooth within a tooth. You can see this radiographically. Do you need to do anything about it? No, you just need to mark that you see it. Tooth fractures. Again, there are classifications for fractures. We don't need to go into them now because you're going to be getting into it a little more this summer. This is what you'll be getting, though. You'll see this. Sometimes they're crying because they're 5 years old and it's a baby tooth. And you have to take an x-ray. Where would you start? Especially on a 5-year-old or a 3-year-old who falls into the coffee table. What kind of radiograph would you take on that patient?
Panoramic?
Maybe.
A PA.
Okay, a PA. How would you do that?
Depends on how young they are.
Okay, this is where you learned about occlusal films, right? The number 4 film. Okay, occlusal films are big films. The only occlusal film I've taken, though, is on a kid, and I take it with a number 1 or a number 2 phosphor plate film or sensor. So I'm going to turn my thing back on. Let's see. And this is if you ever need to do this in private practice. The kid is usually on the mom's lap, screaming, "Ah!" And the doctor's telling you to take an x-ray, and you're looking at him going, you've got to frickin' be kidding me. So you're going to take your sensor, all right, and all the patient does then, the patient will be on the parent's lap, and the parent will have a lead apron on. Then you put the kid on, and the kid's got a lead apron on, and the mother's trying to hold the baby or the kid back. So what you're going to do with the occlusal film is place this in the patient's mouth. It's a regular sensor, but it just goes in like this. Okay, they don't have to bite on it, okay, but you just have to get it placed down. And then the PID is coming for the maxillary. It's coming through the nose this way. And for the mandibular, the PID is coming up this way. And then you'll get the entire area. So they can see if there's any root fractures and things that way without taking a CBCT or a periapical, that type of thing. So don't be afraid if you're ever asked to take one. But yeah, if you can't get a PA, that's what you're going to have to do, is get an occlusal. Tooth malpositioning. When we get into occlusion a little bit more, we'll talk about versions, torso version, lingual version. Is the tooth completely out of alignment or is it rotated? So if the tooth is completely out of alignment, then it is a version. So this would be lingual version. And then buccal version or facial version would be coming out the other way. Torso version is when they're twisted. Okay, so torso version is when they're twisted. That means it's a rotated tooth. What we always do for torso version is take a look at the mesial portion of the tooth and go with the mesial. So this is the mesial here. The mesial is facing the facial. So that would be a mesiofacial torso version versus this would be a lingual version. So when you're looking at occlusion and trying to find all of your rotations, what you want to do is just put this imaginary line through the central fossa. That's your imaginary line, and you're trying to figure out where are the teeth in relation to that imaginary line. Well, this is lingual. This is the mesiofacial version. This might be facially verted, or it might be in complete alignment. So that's why you have to have that imaginary line for malpositioning of teeth. So hard tissue charting asks you to take a look at that. So for this, on the bottom, we've got our central fossas. And what's going on with this canine here? Mesiofacial, torso version. All right, so this is out of alignment. This one looks like it's in alignment. This is facing this way. So how would you classify this tooth? We're always looking at the mesial.
Would that be a distofacial torso version?
It would be distofacial,
yeah,
or
Lingual mesial.
Mesial lingual. And we're always doing it from the mesial surface. Otherwise, it's just a mess with trying to, yeah, it's distofacial, but take it from the mesial surface. Always take it from the mesial surface on your description. So this would be mesiofacial. This would be mesiolingual. This would be mesiolingual, probably. And then you're coming around normally. But can you see where you have to have that bird's eye view to figure out where the teeth are?
Misty?
Yeah.
What causes the tooth to rotate like that?
It could be that there wasn't enough space while the tooth was erupting. It could be that the way the bite is, the way the teeth fit from the maxillary arch. Remember, things want to meet on top, you know, they want an antagonist as well as a tooth beside it. So they just try and reach things. Could be there just wasn't enough room when the tooth was coming in. I don't know.
Thank you.
Occlusion classification. You are going to be doing occlusion classifications on everybody. And we've got a chart on here. What I would recommend that you do is to have a printout of something in what I'm calling your clinic notebook or clinic binder. So you have a ready reference. Those of you that have the dental clipboard have this already on the clipboard. You're going to be doing a canine and a molar classification on right side, left side. You're going to be talking about overjet and overbite. classic class 1 occlusion. Overbite and overjet, you are measuring. So for overjet, you have your probe and you're measuring it here and you're measuring it here and you're making a millimeter. So this might be a 3 millimeter and you're writing down the millimeters. For overbite, it's a vertical. And again, you're dividing the tooth up into thirds and finding out, is it slight, moderate, or severe? So the maxillary teeth should overlap the mandibular teeth at least by a third. Overjet, that's the buck teeth. Underjet, this is the mandible, and then this is the maxilla. So that's a reverse. Cross bites. You're looking for all of this. And you're putting it in the computer. You're telling the computer what it is, but you're also, we have what these worksheets, we call them hard tissue charting worksheets. So you're going to be writing everything down when you're evaluating your hard tissue. And then the dentist is going to come and check it, and you'll be calling out, number 1 is missing, number 2, blah, 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 number 3, blah, 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 number 4 has an implant, and you're just going to be going around that way. They will be correcting you. No, it's really a sealant, it's not a composite or whatever. And then after all of that, you can then place it in the computer after the dentist has checked. Different restorations, you want to be able to use your radiographs for the restorations, right? This is what, of course, it looks like, an implant looks like on a radiograph. Root canal, crown, lots of crowns, furcation involvement. So when you're looking at rotations, let's take a look at this central right here. How would you classify that rotation?
Mesiofacial.
Yes, MF. Torso version, yes. You're using your radiographs to help determine the type of restorations that your patient has. This is a composite. This is a very shallow, this is kind of what my amalgams look like, because I didn't really have cavities. They were just filling in pits and fissures. This could be amalgam. It could be gold. This is porcelain fused to metal, PFM. This is the porcelain here with the metal inside. You can see more composite. This looks like decay, but we don't know. We have to take a look inside the mouth to see if this is a restoration here and it's a liner, because some dental restorations you can't see.
SD, is that PFM a crown? Because it doesn't look like a crown, but.
This one here?
Yes.
Yes.
Okay.
Yeah, because you can see right here the tooth form here.
Yeah.
And this is the metal. Is this a good bite wing? Are either of them good bite wings?
Not really.
No, they're not really. At least this one you can see the distal of the second premolar, fair amount of overlapping there. Don't even see bone here. Why didn't they take a vertical bite wing? This just infuriates me when I see stuff like this. Dentists like horizontal bite wings because they can see what they need to see, and it's easier to open up the contacts on horizontal bite wings than it is on vertical bite wings. But you can see we're missing a whole lot of information from that. How would you chart this?
No way.
Surely this is like 1 in a million, right?
I don't even know if it's true.
We dismiss the patient.
It's just, at first I thought, oh my God, but somebody must have been photoshopping. You know what I mean?
Yeah, definitely.
So I'm going to, let me see, stop this share because you have an assignment that is coming up in a week or two. And I thought I had it out and I don't. So, okay, I have to find it. So what did you all do yesterday? Did you enjoy your day or were you getting caught up? I saw a lot of dental cares coming in and that type of thing.
We were studying. We have exam tomorrow.
I don't know.
Do you have your tutoring set up, your review sessions? If you want them, use them. All right, so this is, again, something that you can print out and have in your clinic notebook or clinic binder. This is just one of the ways you can chart. Now, what we're going to have you do is on all of your, we're calling them test patients right now, but we want you to have experience on not only the computer, but also on the handwritten charts. So on 10 patients throughout your time here, they will be assigned to you. You are going to do hard tissue charting on paper, and this will be the guide on how you do that. Partially erupted, shade in blue, PE at the root tip, supernumerary, draw in tooth in blue and circle it in red, root canal therapy. All right, let's see, sealants, blue S, amalgam restoration, appears as it does in the mouth and it's all blue, versus composite are blue, but they've got little dots on them. Gold will have slashes on them. So this will be your guide on how you can chart things. And then,
Miss D, where I can find the sheet that you just showed us.
it should be, let me see, somebody said it was in week 9, something was in week 9.
It is on Canvas at the end.
At the end, okay, hard tissue charting exercise. All right, so all of this is in Canvas. I'm just not sure where it is right now.
I think it's on Clinic Help, Misty.
Under Clinic Help?
Yes.
Okay, this is, let me see if I can get this up so I can screen share. This is the assignment. Are you seeing this hard tissue charting exercise?
Yeah, I saw.
Okay,
that.
so
thank
this is the assignment, and what you need to do is go through and chart. Number one is impacted. So how would you chart an impacted tooth? And then you're going to chart it on here. So how are you going to say it? So if the doctor's on sitting down with the patient, how would I say number one is impacted? Number one's not present, number one's impacted. However you want to say it, that's what you're going to be typing in or writing in here. You're also going to be drawing it in for number one. Number two has an occlusal amalgam. So how would you be drawing an occlusal amalgam? So you'd be drawing in an occlusal amalgam here, and you'd say number two, occlusal amalgam. Number three is super erupted. That's a straight line. Number three, super erupted. Number four has a distal occlusal composite. So that is a DO composite. DO composite is how you would say it, and you draw in your DO composite on number four. So forth and so on. Now, and you're just going through each and every tooth. You're writing down how you would say it over on this left side or right side, and then you draw it in how you would draw it in. So there's wiggle room here, my friends. This is not all or nothing. What we're going to be doing is going through this as a group. I want this to be your own work. Try and interpret what we've given you, and we'll go through it as a group. If everybody knows that number three is super erupted, how you wrote it, that's good. It might not be exactly how the person next to you had done it, or it might not be precisely like what was written on that other form I showed you. But again, this is a universal language that everybody needs to be able to understand. So if you have erasable pens, this is where it really comes in handy, the blue and the red erasable pens. Pencils are fine, blue and red pencils, they tend to just kind of, they're difficult to keep sharp. Some people have found lead pencils, mechanical pencils in red and blue that they can use too. So that's what this exercise is.
Should that be on Canvas too, Ms. B?
This is on Canvas as well. And we're going to go over this in clinic.
Okay, so we don't start this yet until we get a demonstration of it, right?
No, this was the demonstration.
Oh, okay. So are we supposed to have this done by Monday?
No, somebody said the 9th. I thought it was
Yeah.
due on Monday, but somebody said it was the 9th. So I'm not sure right now.
It says it's due on the 9th on Canvas.
Okay.
I think on Canvas it says the 9th, but on the syllabus it says the 2nd or something like that.
Yeah, I'm going by the syllabus and not Canvas. So that's why I thought it was due on Tuesday or on Monday.
Yeah, that's what I have too.
So I would count that as Monday. So let me.
So we have our philosophy of practice due Monday, as well as the hard tissue charting exercise.
You got a lot of stuff due on Monday.
I think the article critique is due that day too, isn't it?
Yes. Okay. So can you all see the Canvas?
Yeah.
site?
Yes.
Okay. Philosophy of practice is due November 2nd. All right. So I'm going to click on that. All right. And this is the rubric for the philosophy of practice. You can upload your file so it can go directly into Canvas. Topics you should address. All right. Now, a number of you have already done this. All you need to do is in paragraph form, answer these questions and embellish, add more information or not more information. I mean, depending on what you want to do. What aspects of dental hygiene attracted you in wanting to pursue a dental hygiene career? What brought you here? That's a paragraph. What is the most important role you see as a dental hygienist? 99.9% of you are going to say education. All right. There's no right or wrong on this. What type of practice do you want to find yourself working in? Do you want to work full-time? Do you want to work part-time? Do you want to work in a large office, in a corporate office, in a small dental office where it's just one doctor, one receptionist, and one assistant? I mean, what type of practice do you see yourself working in? And do you want a specialty practice? Do you want pedo? Do you want perio? Are you interested in advancing your dental hygiene education beyond the associate's level? Some of you already have a bachelor's degree. Some of you already have a master's degree. Some of you know you want to get into public health. Some of you might want to pursue teaching or research or even sales, because to get into a sales position, you need to have a bachelor's. Or is this going to be it? Or do you think you're going to be happy with clinical dental hygiene? There's no right or wrong to this. Do you want to be involved in your professional association? Do you want to be a member who attends meeting, or do you want to be a member who's a leader of the association? I am one of those that started out as a member, and I was dragged in very early, my first year out, and I drank the Kool-Aid, and I've been an active member ever since. I'm on both state and local level. I'm doing local continuing education for the association right now. And I just had my first big online meeting. We had, I think, 120 people attend for our OSHA update last Thursday. Scared the crap out of everybody. And then there's a rubric here, so you'll see what you're being graded on. And for this, okay, I've got everything here, but you don't need to print out the rubric because that's going to be in the grade book, but you've got a total of 9 points. Addresses the 5 topics suggested. Your writing mechanics, and did you submit it on time? I mean, it's an easy thing. You don't need to have references unless some students like saying, well, the definition of dental hygiene is, and that's fine too, but it's not meant to be a difficult assignment. I don't want it to be a difficult assignment. And this time next year, you will be readdressing these same issues and writing another philosophy of practice and seeing where you want to be this time next year. Now, the research article critique, okay, to turn it in is here as well. And this is Canvas. So this is the article critique. All right, it's got the criteria on you here, and it's got the rubric, but that again is in Canvas. So when you go into submit it, I'm going all the way down. Philosophy of practice is due. This is where you turn that in. And your article critique is due here. All right, so you're going to be able to upload it there. I am trying to wear my big girl pants and get rid of paper. I like having my article critiques in front of me because I like browsing the article first, and then I go to the article critique that you wrote on that particular study. But again, I'm trying to wear my big girl pants.
Misty?
Yes.
The article critic, it says we need to attach the link. So do you want us to attach a copy of the website that we used, or the whole entire pages?
I need to be able to pull up your the copy of whatever you use. So I don't need the whole JADA magazine. I want just that study. So
Okay.
It could be a PDF of something that you've saved, or it could be a link.
Okay, thank you.
As long as I can get to it.
Misty, So you
Yeah.
said that you're gonna have us do hard tissue charting on Monday as well.
Yes.
Okay, so submit all of this 3.
Well, the hard tissue you're going to be bringing into clinic.
Oh, okay.
All right. So what I'm hoping to do is Monday morning, hopefully each group of 6 of you can go into the bookstore and pick up your stuff 6 by 6 by 6. Okay, we'll do it that way because we need you to go through and get your slow speed handpiece, your polishing handpieces out to be autoclaved so we can demonstrate polishing in the afternoon. So we will do probably fluoride varnish in the morning and polishing in the afternoon, as well as do the skill evaluations for both of those that same day. We will catch up also on other skill evaluations as need to be done. So we're about 2 weeks behind now on where I want us to be.
Misty, I don't see the hard tissue assignment on Canvas.
Well, that's where I found it. So let's see. Hard tissue charting exercises, week 10. Down at the bottom.
The PDF that you were showing earlier, it's towards the top. If you look at the top under syllabus plus course information, there's
Okay, so I've got it there twice because can you see my screen?
Yes.
Okay, this is what I found. Oops, get out of there. This is what I found under week, wherever I was.
You were in week 10.
Week 10, so it's there. And Jonathan's saying if I go all the way up top.
It's right there.
Yeah, it's right there. Hard tissue charting.
Oh gosh.
Oh yeah.
And so this is due the November 9th and not.
Okay, we're going to make it November 2nd.
Okay, 2nd.
And you're gonna get back to us with assigning this assignment, Misty?
I'm sorry? Well, I didn't hear your whole question.
I thought you said you were gonna assign us with this, like group wise. So are you?
No, you're gonna all do it individually now. We're going to review it as a group.
Okay.
And this is due the 7th, you said, right?
No, this is due the 2nd.
Oh, the 2nd. Okay.
Mhm.
Okay, so do we upload it here on Canvas?
Nope, you're going to bring it in. You're going to print it and bring it in.
Oh, okay. Got it.
Yeah, print it and bring it in. And as a group, we'll discuss it. You'll compare what everybody did, and then you'll come to a consensus on looking, what is the best way to chart this again. So everybody understands what your PFM, porcelain fused to metal crown, is supposed to be charted like. So Jennifer says you're going to print it, fill it out on your own, and bring it in on Monday to discuss as a group. Yes.
Misty, are we going to get graded on accuracy of all of it? I'm just so, I need to go back and obviously rewatch everything, but will the complete accuracy be graded, or that we tried our hardest?
It's going to be that you tried your hardest.
Okay, thanks.
No, it's, we're not out to get you on this. Just try your hardest. I mean, everybody's going to be getting a grade, but it's going to be a nice grade. It's going to be a nice grade.
Misty, for Navigate to on week 10, are you going to change the date then? It should be on November 3rd. Is that correct? Okay.
Um, for hard tissue, yeah. And then if we don't get to it, we can put it off, but at least you'll have it done. Are we good?
Misty, so for the hard tissue charting, I know there was a part where you said how we're gonna say each of the listed